The Expanded Program on Immunization, or EPI, is one of the most successful global health initiatives, saving millions of lives each year by preventing infectious diseases. In the Philippines, EPI serves as a major component of maternal and child health services. As nurses, understanding EPI is vital because we play a frontline role in vaccine delivery, health education, and monitoring for vaccine preventable diseases. The Expanded Program on Immunization is a WHO led program adopted by the Philippines in 1976 to protect every child and mother from vaccine preventable diseases, or VPDs. It is implemented through the Department of Health in partnership with local government units and rural health units, barangay health stations, and community health workers, such as community health nurses, midwives, and barangay health workers. The EPI is anchored on universal access and quality care, promoting equity, ensuring that even those living in unserved and underserved areas receive life saving vaccines. This reflects the principle of primary health care: accessible, community based, and equitable health services. EPI has an enormous public health impact. It is a cost effective strategy for reducing infant and under 5 mortality and morbidity. Vaccines prevent illness and death, but also the long term disabilities caused by diseases like polio or measles. Immunization also builds herd immunity, meaning when most members of a community are vaccinated, it limits the spread of diseases, even protecting those who cannot be vaccinated. EPI aligns with SDG 3, which emphasizes good health and well being for all. Furthermore, it is integrated with maternal, newborn, child, and adolescent health services, reinforcing continuity of care from pregnancy to childhood. The general goal of EPI is to reduce morbidity and mortality caused by vaccine preventable diseases among infants, children, and mothers. It aims to sustain the polio free status of the Philippines, maintain neonatal tetanus elimination, and prevent measles outbreaks. Another goal is to ensure that immunization services are safe, of high quality, and accessible to all, from cities to remote barangays. Nurses, therefore, must ensure that cold chain systems are maintained, vaccines are administered safely, and coverage is monitored continuously. The specific objectives of this program guides its implementation. 1. Achieve and sustain at least 95% fully immunized child or FIC coverage in all LGUs. This ensures that almost all children are protected. 2. Strengthen surveillance, cold chain, and AEFI or adverse events following immunization systems. Nurses must be trained to identify, document, and report these AEFIs properly to maintain vaccine safety and public confidence. Third is to reach missed children through catch up campaigns and supplemental immunization activities or SIAs, especially in communities with low coverage. These objectives require strong collaboration among health workers, LGUs, and the families. The Philippine implementation of EPI is officially known as the National Immunization Program, or NIP. It was established by the DOH in 1976, and its legal mandate is provided by Republic Act 10152, or the Mandatory Infants and Children Health Immunization Act of 2011. This law requires all infants and children to receive basic immunizations against common infectious diseases. It also mandates the government to make vaccines available, especially for marginalized populations. So, when we talk about EPI and NIP, we are referring to the same public health system, one guided by national law and implemented through the DOH and LGUs. Who are the priority populations under EPI? We have the infants, or those children aged 0 to 12 months. They receive the primary vaccine series such as BCG, hepatitis B, DPT, Hep B and Hib are the pentavalent, the OPV and measles containing vaccines. Another priority population are the children under 5 years old, or the UFCs. They are included in catch-up doses or supplemental campaigns to ensure full protection. Pregnant women, they receive tetanus toxoid or TT or tetanus diphtheria or TD vaccines to protect both mother and newborn against neonatal tetanus and diphtheria. Another group are the women of reproductive age or the WARA or WRAs. Immunization of these women of reproductive ages 15 to 49 years of age contributes to the maternal and neonatal tetanus elimination or MNTE goal. Another group are the vulnerable and indigenous groups, especially those living in the unserved and underserved areas. They need to receive focused outreach through mobile vaccination and community caravans. These populations are prioritized because early life and maternal periods can carry the highest risk for severe outcomes. Now, let us reinforce these target groups and understand their rationale. Infants and young children are at the highest risk of serious illness and death from infectious diseases because their immune systems are still developing. Pregnant women who receive the tetanus toxoid vaccine pass passive immunity to their newborns, protecting them against neonatal tetanus. Community level herd protection occurs when enough people are immunized, reducing the chance of transmission even among unvaccinated individuals. Nurses must therefore ensure that no child is missed and that every mother receives the care and information she needs. In the end, immunization is not just a medical intervention. It is an act of community protection and social responsibility.